For TB, after that engagement, 164 pupils came up saying they have cough that has been persistent, they have chest problems and so on. So what we did was basically to list them. Because there were many people listing, quality control was difficult. We hope to go back and then review these children very well and if possible do the screening. And we are surely moving with the surveillance, with the DTLS will make a very big difference. He has been on the ground, he's been very supportive, and he has given us a very good orientation. We appreciate you, sir. Yeah, so leprosy, again the global picture, we have 200,000 cases in the whole world. And 400, in Uganda annually we record 400 cases every year. This number, that is the average. So it can be slightly up, it can be slightly below that. So we are actually dealing with quite a very big problem. And I want to thank IDI for the role that they have been playing on the ground with the CAST plus interventions. Yeah, so based on these statistics in the world, our vision, of course, is to make the whole world a safe place for everybody. So we have, as WHO, the End TB global strategy that aims to reduce TB death by 90% and new cases by 80% by 2030. And to do that, there are a number of interventions that we prescribe. Those interventions include prevention, so we can examine ourselves, our district, how well are we doing with prevention. Some of these strategies for prevention of TB and leprosy have already come out here, and we have also seen how we have done in some of them. For example, vaccination. This is the simplest and the most universal, but we performed at 63%? 60, yes, that is the newest. Meaning that 37% of our children remain at risk of getting TB. And you might also know that the bacteria which causes TB is a cousin of that one that causes leprosy. So, is it possible that this vaccine could also be a good antidote for leprosy? I don't have the answer yet. But if they are cousins, and this one can prevent TB, then maybe there is something that we ask for leprosy as well. Then two, the second intervention that we recommend is early detection. Again, when I looked at the presentation of Dr. Paul, we are at 65%, meaning there are 35% out there that are not detected. Some of these could actually be multi-drug resistant cases. That happen in our country to be 2%. 2% of all the cases that are detected are multi-drug resistant. And one case can infect over 100 people in one day. It is a behavioral disease. All these are behavioral diseases. And they spread also in similar ways. Airborne droplets, and of course through, you even increase the risk through close contact. Yeah, so it's something very, very important. Then the other one is contact tracing. When we pick one case in this home, we need to list all. We need to list all those persons that have been living in proximity with this person for monitoring, but also if they're symptomatic, we also do what? Testing. Now, I see that 41 persons tested positive. Our presentation had a gap on that. We did not show how many persons we have contact listed against the 41. So that remains an action point for the team that will be moving on the ground. Let's do the contact listing. Yes, then the other issue is treatment. Again, I took note that out of the 41 that tested positive, 27 have been enrolled. The others are still missing. This could be because of stigma. So we need to reach out to them and find out what the issue is. This could even help us actually to support the rest that are remain undetected. Yeah, and the good news is that the success rate with the treatment that the DHO reported is 94%. Meaning that for every 10 that we enroll, 9 are going to, at least 9 will cure, will recover. The other one could also cure. The problem sometimes is to do with adherence. But if everybody adheres, which is a behavioral issue again, we could be able to hit 100%. Another important strategy that we talk about is raising public awareness. If you closed your eyes and looked at the community, out of 10 people, how many do we find aware of the signs and symptoms of TB, its transmission, where to get treatment from, and of course, how many? And then you also apply the same to TB, you will find that our awareness levels are quite very low. I'm told that when the team went, for example, to Kololo, for the screening, the team that did a very good job to pick us, for us, the 22 cases in that particular school. Yeah, well, they did not go class by class, but they did a good job. The component that missed was that part of first preparing the risk communication component, helping them know what are the symptoms and signs and so on. So some of them actually that tested positive remained a bit hesitant. When they called the police, if you have this and this, come in front. Many of them a bit were hesitant. Going forward, if we can incorporate that component, we'll do better. We did that yesterday, and as I told you, 164 came out, including those that we felt we didn't have cough. Including those, but also others coming now to report people in their homes. So it's something that we need to. It will also help us fight stigma, but also lead to behavioral change. When I interacted with some people, including patients, even those of leprosy, many of them think that TB and leprosy, as Dr. Paul put it, are caused by a curse, are caused by tears, are caused by injustice. You take somebody else that one told me, me I got leprosy because my father did not pay enough bride price, so my uncles were not happy. Right? They were not happy. And then the other one said, they did not bury my grandmother very well, my maternal grandmother very well, and the family got angry. So now when my paternal grandmother died, they did the funerals very well, and the cast came, and I felt sick. That's how I got it. Same thing with TB, but this kind of conversations will surely be good. Yeah. And so I'll just add to some of the action points that might be very important. One of them is that we need to constitute and activate the different pillars, at least for the next 3 months. Those that I see very, very important will be surveillance. That will do, of course, support the screening, support contact tracing, and of course detection of these cases, line listing and all that. The other one which is very, very important is the risk communication and community engagement. Sometimes we call it social mobilization. Yeah, and this should bring in, as Dr. Alex put it, bring in the traditional healers, because they are some of the points of care seeking that we should be going to. I was informed, Dr. Alex, one of the cases recently was picked from one of the traditional healers, and her body had wasted. She was 49 kilograms. Now she's on medication. She has reached 60 kilograms. Yeah, but it's one of our PhDs that did a good job, because IDI had done a very good orientation. Yeah, traditional healers, the religious leaders, the politicians, please, you are the people that our communities believe in most. When you say we have TB, it is not caused by cats, it's not caused by witchcraft. People listen to more than me, who is a stranger. Please play your role when you go for burials, when you go to church, wherever you go. When you go for an introduction, deliver this very useful message and tell people the signs, symptoms, and where they can pick. And then we need to chair and incident command. We need to develop a 3-month costed response plan. You called it a concept note. We call it a response plan, costed response plan. That captures all the key pillars. We talked of surveillance, we talked of RSS, we talked of case management, and then orient our people when they're going to a community. As the community, many people will come out and will all be standardized in operations. We need to develop a 4W matrix. A 4W matrix identifies who are the IPs on the ground, who is working in which sub-county, which sub-county has not received the support, for how long is this person here, what are the activities this person is doing here, what are the resources that this person is bringing to which pillar. It is very, very important for planning, for resource mobilization, and for coordination purposes. The line listing, I've talked about it. We need to do it more systematic at this time, class by class. When we also went to that school yesterday, some classes were missed, and then list those that meet the case definitions and pick the samples. The one challenge again is about the turnaround time for results. These samples were picked on 11 to 14th of 1 month. That person who had TB has infected other people. So we need to reduce this to a maximum of 3 days. The other persons, we are going to enroll the 27. Then reactivating active case search. And of course those that have the 50th floor and above. They used to come to schools and they tell you, all of you stand in the lines, remove your shirt, and they bring a feather. Screening, that helped us to improve early detection. Can we do that in all our schools? It's very simple. And in one small classroom, this is bigger than that classroom. 450. That is a whole school. P1 alone. P2 had about 280. P3 had 380 plus. And then now you go to P4. And as he said, P7 had 55. I was shocked. From 450 to 55. Less by 9 times. Reduced by 9 times. And of course, that's, as I said, education is a very important moderator. Classes which are really too congested, if we can develop plans for temporary facilities to separate. Because look, if you only have 2 cases of TB in the middle of 450, you imagine what happens by the end of the term. So we need to have that discussion. Lastly, Madam Chair, this issue came out. Many of our patients are joining. They're having patient-led and owned circles, including persons with leprosy, patients with leprosy. They're trying to do self-help. They come to the facility every week. And the more activities